Hi guys. So we are going to actually finish up this last bit for the test and talk about the urinary system. Now we've talked about acid-base balance and about water and solute balance throughout the body. So now we're going to get into how the body actually utilizes or filtrates out solutes and allows water to be excreted when we're essentially done with it. And so the main organs that we're going to look at in this is essentially the kidneys. We're going to focus most of our time on that, and then we'll talk really quickly about the uterus, the urinary bladder, and the urethra. And as you can see, there are some vessels responsible for blood going to and from, as in the renal artery and the renal vein. In the kidneys, and we'll talk really quick about the renal hilum as well. And so let's focus on the kidneys first. The kidneys are a major excretory organ. It helps to maintain the internal body environment by basically regulating total water volume and total solute concentration in the water. And we talked about this at the end of our last lecture when we were talking about how water moves, and essentially water moves wherever salted is. It really likes salt. And we have hormones in our body that allows us to either reabsorb solutes like sodium or get rid of them through our urine. So we're going to talk about how that works in the kidneys. Regulating ion concentrations in the extracellular fluid. So if you remember, the extracellular fluid are things like your plasma or interstitial fluid, or fluid that you find in body cavities or between membranes, like lymph fluid or the cerebrospinal fluid, all those things. Ensures long-term acid-base balance. If you remember, we talked about acid-base balance and how your body responds to if your body gets too acidic or too basic through basically the processes of either respiratory acidosis or alkalosis, or metabolic acidosis, alkalosis. We talked about excreting metabolic waste, or what metabolic waste is in the past, like urea, uric acid, toxins, and drugs that you may be taking. And it's important in erythropoietin production, which helps to regulate blood pressure, and renin, which helps to regulate red blood cell production. It's also important in activating vitamin D and carrying out gluconeogenesis, which we really didn't get a lot of time to talk about. This is where you would find in basically nutrition, and this is a process of making glucose from non-carbohydrate sources. And so the kidney is part of the overall urinary system, which we pointed out really quick in the picture, which has the uterus, which helps to transport urine from the kidneys to the storage reservoir known as the urinary bladder, and then urethra helps to take the urine from the urinary bladder out of the body. And so this is essentially the internal anatomy of the kidney, and we looked at this when we dissected it. And so it's made up of two main areas. You can see right here, you can see it's made up of the renal cortex and renal medulla here. You have some of these major areas that we're going to hit on. You can see here coming what will end up going out of the kidney and then essentially go to the urinary bladder is the ureter. That's right here, that big thing. Now on here, you can see when you're talking about this main area here, you have the renal pelvis in this area here. And then essentially it's going to go and get a little bit smaller, and you're going to notice that's the major calyx here, and the minor calyxes are a little bit farther out here. Now the renal pyramids are these basically pyramid-shaped objects that are in the renal medulla, and between those, you can see here, are the actual columns. On the outside of this is going to be the fibrous capsule, and that essentially gets your main, and of course this is the renal artery, and this is the renal vein here, and you can see them throughout in this area on the outside. So when we talk about the kidney itself, within the kidney, there are these small structural and functional units that are called nephrons. And nephrons are responsible for the formation of urine, and there's about 1 million of them per the kidney. And each one essentially contains two parts. It contains the renal corpuscle and the renal tubule. Now, of these two parts, the renal corpuscle is actually made up of two things. One is called the glomerulus, and these are just these small tufts of capillaries that are composed of the fenestrated epithelium. So if you remember the fenestrated epithelium, they talked about this actually being very highly porous. So it has a lot of holes in it, right? And that makes it really good and efficient for making filtrate. So this is where you're going to have filtrate formation. Infiltrate is just plasma-derived fluid that basically that the renal tubules will process later to form urine. Now, another part of this is what's known as the Bowman's capsule or the glomerular capsule, and this consists of two layers. The first is the parietal layer, and then that clings to, this is the part that actually clings to the glomerular capillaries. And this has what's known as branching podocytes in it. And you're going to be able to see pictures of all of these, right? And so basically these podocytes, you'll notice they have like these kind of, at the end of them, they have these feet processes that cling to this part that's a basement membrane. And there are actually filtration slits between these little foot processes that allow the filtrate to pass into the capsular space here. Now the renal tubules, this is a little bit bigger. This is about 3 centimeters in length, and it has 3 major parts. You have the proximal convoluted tubule, which is the part that is basically closest to the renal corpuscle, right? From there, it leads into the nephron loop, and then the distal convoluted tubule is the farthest from the corpuscle, and this guy is actually going to drain into the collecting duct. So let's take a really quick look at the location and structure of the nephron really quick. So as you can see here, we're kind of in the middle. You can see we're going right here. The cut is there. And so on this top part is where you're getting the basically the cortex. And you're going to see on here is this beginning area that we talked about, the glomerulus up here, and the basically the renal corpuscle. And then when we get into the renal tubules, will be once we hit out into this area right here that you see the line. So I want to see. As we're going into here, you can see that you have arteries going in here. So this outside part that you're seeing right here, you're actually seeing the glomerular capsule area. And then if you look up here, you can see the outside is kind of this parietal area that basically is just going to have the single layer of cells. But if you look on the visceral side, that being towards the inside, you're going to see basically where you get those epithelial cells located there, and they're really, really thin. So, and these podocytes that are on the top of it. So we're going to be able to get some of that filtrate going through those different layers there. And so once it comes in here, you'll see the glomerulus here in the middle with all those lines going around, and then the capsule on the outside, also known as the Bowman capsule. Once the filtrate goes into there, then it's going to go out here, and you can see that this first area is what's known as the proximal convoluted tubule. Now in here, you can see that's these cells right here, and so there's these basal membrane, this basolateral membrane that's on the bottom, and then you'll notice at the top there's these apical cells on one side, and that's where we have basically microvilli, which are these really small kind of hair-like structures. These are brush border cells basically. They help to, these little microvilli help to increase surface areas. And so this guy right here is going to be important because it's going to help with functioning with reabsorption. Actually, sorry. And secretion. And this one, as you can see, is found in the cortex. Now, if you go a little bit farther, you can notice about right down here, all the way around, it stops. If you look here, you can actually see it. Where the size changes, where it gets like thinner, that's what's known as the nephron loop. It is also known by the name of the loop of Henle. That's what it used to be called. That's what I learned it as, but now they determine it as the nephron loop. So you have one side, if you notice, this is the descending side because essentially we're going down this way. And up here is the ascending side, right? And from here, once it passes there, it's going to go, if you notice, this is essentially in the medulla area right here. And then we're going to go into, once you get bigger, this thicker segment up here that's called the distal convoluted tubules here. And as you know here, this guy, again, has that basolateral side on the side and the apical at the top. And this guy is going to be mostly known. They have very few microvilli, so not a lot of the microvilli or villi here. Here we have a lot of them, right? You see that. And so in this area, because of that, it functions more in secretion than it does absorption. And you can see this guy is also confined at the top right here to the cortex. And then this last part here is the collecting duct. And so this is going to receive filtrate from many neurons. Let me write that on here. Receive from many nephrons. I think I said neurons. I'm sorry about that. Nephrons, right? And so the collecting duct, I'm going to move this over here so I have more room, basically runs through the medullary pyramid. And that's what gives them the stripe appearance that you see. And ducts fuse together, right? So ducts will fuse together to basically make those what are known as minor calyx there, right? So that essentially is the structure of the actual nephron. Now, when we look at the collecting ducts themselves, the collecting ducts, let me go ahead and erase this really quick. So if you look at the collecting ducts themselves, you'll notice that they have two types of cells down there. They have, what's known as the principal cells and the intercalated cells. So the principal cells basically help to maintain water and sodium balance. And then these intercalated cells help to maintain acid-base balance in the blood, or for the blood, may say. And they're normally known as either type A or type B intercalated cells. Now, if we look at neurons, there's actually, or nephrons, I'm sorry, they actually two major groups of nephrons. They're what are known as the cortical nephrons, and they're, out of all the nephrons, they make up about 85% of them. And basically, you can find these mostly, you see how they're called cortical nephrons? They're mostly found entirely, almost entirely in the cortex. And so you can see these up here where it talks about or shows you the cortical nephrons up there. Now, the juxtamedullary nephrons, these are essentially nephrons that have long loops, as you can see on this one, right? They have both thick and thin. As you notice, I have that one right there, and it's basically in thin segments there. And they're important. These ones are more important in concentrating urine. Okay. And if you look at this, they essentially, if you look at this, you can see that when they're talking about supplies or what supplies these two types of nephrons, essentially the vas rectus supplies the juxtamedullary nephrons, and for the cortical nephrons, they have two supplies. They have both a supply from the glomerulus capillaries here, or through the peritubule capillaries. So when you're talking about getting blood supplies or filtrate, these are the two places for the cortical nephron. And then essentially, if you look down here, that is the main place for the juxtamedullary nephrons. And so the juxtaglomerular complex, which is known as JGC of the nephron, looks like this. And as you can see here, you have the complex. So when we're looking at the outside, right, you have these efferent arterioles that come in through here, right? And then you can see these are the lumens of all the capillaries. So everything you can see goes in here. And then you can see basically the lining here and those podocyte cells here. So you can go out and it goes out through here. And then you can basically say that parietal layer that's on the outside. So essentially that's this visceral layer that's in here, right? And then of course it has some capillary space between the two. Now, when you're looking at the cell populations within this juxtaglomerular complex, there's basically three types. You have the first one is the macula densa cells. And these guys basically have chemoreceptors that help to sense sodium chloride that's in the filtrate itself. You have the granular cells right there. You can see they're kind of large, smooth. And these are essentially muscle cells. So basically what these guys do is they act as mechanoreceptors and they help to sense blood pressure. And that happens if you notice that they are in the afferent arteriole. They also, on top of just sensing blood pressure, they have secretory granules in them that contain the enzyme renin. And then you have the last guy right here that I'm going to talk about, and it's the extraglomerular mesangial cells, and they serve as a messenger between the macular densa cells and the granular cells, right? So let's just review these three really quick, right? You have the macular densa cells. Remember, they have chemoreceptors. So receptors that can detect chemicals, and the chemical they sense in the filtrate is sodium chloride. The next is the granular cells, and these are large smooth muscle cells of the arteriole, and basically they serve as mechanoreceptors. So they're the receptor that basically can detect a mechanical change, which that change is sensing blood pressure differences in the afferent arteriole. They also contain these granules that contain, or these cells that they can also contain these small granules that they secrete that contain the enzyme rennin. And the last one is this mesangial cell that's here, the extraglomerular cell, and that's the messenger that allows the macular and the granular cells to talk back and forth. So that's essentially reviewing really quick over the actually nephron that works. And so that basically talks about the three, and you can write in there any of those that you would like. So it shows it again. And so when we're talking about this in the sense of these are located in the kidney, and the kidney is actually going to help filtrate. So the kidney filtrates out, filtrates the body's entire plasma volume 60 times each day. So that means they are essentially processing about 800 liters of fluid daily. But even though they process that much, only 1.5 liters of urine is actually formed each day, which is an amazing feat. Basically, this process uses quite a bit of energy, so it consumes about 20 to 25% of the oxygen used by the body at rest. Essentially, the filtrate produced by the glomerular filtration that we talked about, that anatomy, is basically blood plasma minus proteins. Urine is produced from the filtrate, and basically, urine ends up being what we talked about 1% less of the, or less than 1% of the original filtrate. So not a whole lot of it ends up becoming urine. And in that urine, it contains things like metabolic waste and unneeded substances, which is why we get rid of some of it. Now, there's three processes involved, and that's glomerular filtration. And so this is where we're going to produce cell and protein-free filtrate. Tubular reabsorption. And this is where we're going to get about 99% of the substance get selectively returned from the filtrate to the blood and the renal tubules and the collecting ducts. And then tubular secretion, which basically we selectively move substance from the blood to filtrate into the renal tubules and collecting ducts to be released. And so let's talk about the major processes here. So here we're going to talk about glomerular filtration. If you look at this picture, it shows you all three of the processes here. So if you see here in the red, basically we have this cortical artery coming up into the afferent arterioles, and then you can see it's over here in that Bowman's, that glomerulus here, and that's going to be transferred essentially. The water and everything else will be transferred into the glomerular capsule, right? Now on here, essentially whatever doesn't get filtrated around will go off to the cortical radiant vein, right? Now, what we do, though, is as it goes through here and as it goes through this collecting duct where urine is being passed, all this that comes out in number 1, right, will come out into that Bowman's capsule, into the initial as the proximated convoluted tubule, then through the nephron loops, and then through the distal. And in that process, you can see as it's going out, basically the tubular reabsorption will go so that it goes back into the veins that are it's going to go back into the body. And then anything that we really don't want there is going to come out at the last so that it can be secreted as urine. So this glomerular filtration is a passive process. This doesn't really require no metabolic energy. And what's happening here is this is all dictated by hydrostatic pressure. And you can remember when we talked about that at the last term, right? So basically hydrostatic pressure is when fluid, pressure forces fluid and solids through the membrane because of the pressure. In that it goes into the glomerular capsule, which is essentially the Bowman's capsule. This will allow both water and solutes that are smaller than plasma proteins to pass. No cells leave here. Absolutely no cells. At this part, there's no reabsorption that goes back into the capillaries of the glomerulus occurs at all. Once it moves into the capsule, that's all it is. And so if you see, this is the glomerulus right here. It's kind of done up, and you can see all these little pores, and then you can see the podocytes here in the small feet. So essentially, the fenestrated endothelium is here at this layer, you can see, and because it has so many of those pores, then you can get fluids to come out of them, and then that is essentially has a basement membrane below these. You can see it says the glomerulocapillary epithelium. Podocytes cover the basement membrane, but they've been removed here. So underneath these is the basement membrane, and it basically fuses the two layers together. And basically the last are these podocytes that you can see, these feet that come out here, right? And they have filtration slits, or these small slit diaphragms that will repel big macromolecules but allow small, basically water and small solutes to come through. So any kind of so let's actually show a close-up picture so that maybe you can figure this out a little bit. So this right here is the plasma that's coming through. These are those little pores that we were looking at in the fenestrated epithelial tissue, right? And then essentially, these are the little podocytes or feet that are going on here. So what can happen here is as we go through this, big giant macromolecules get stuck in this filtrate membrane. So they get stuck, and because they get stuck, and then later you can have some of those glomerular mesangial cells will come and get them. Because of this, it allows molecules that are smaller than it's about 3 nanometers to pass. So when you see this stuff that's coming out here, it says filtrate in the capsular space. Basically, what you're looking at coming through here, you're getting water, you're getting glucose, you're getting amino acids, not proteins, because proteins are macromolecules and they're so too big. And then you're getting nitrogenous waste. Now the plasma proteins, they're big and they're going to remain in the plasma or in the blood, and that's going to basically maintain what's known as colloidal osmotic pressure. So just having the solute or some kind of molecule there to make sure that the pressure, the osmotic pressure, remains same. This whole process prevents loss of all water to the capillary space as well, the plasma membrane. The plasma proteins remaining in the plasma will make sure that some water remains. And so all of that's going to happen here though. So there's certain pressures that promote filtration formation. So you have hydrostatic pressure in the glomerular capsule. So that's known as HPGC, and that's essentially important in glomerular blood pressure, or the pressure of the glomerulus, right? And so this guy here, you have chief cells that are pushing water solutes out of the blood, and this pressure is normally about 55 millimeters of mercury. So this is the reason why this pressure is the reason why that efferent arteriole is a high resistant vessel, and it has a diameter that's smaller than the efferent to make sure that it pushes water and solute out of the blood, because you're going from a bigger area to a smaller area. So we need that pressure to stay somewhat high to promote filtration or filtrate formation. And so this is outward pressure, the pressure that affects filtration. So this is the outward pressure that we're looking at that's trying to force water and solutes across the membrane to basically filtrate out or cleanse the initial capillary blood. Now you do have an inward pressure that is happening as well later on. And so you have, or in the same area, you have forces that inhibit filtrate formation. So if you look back here, the glomerular pressure, that's HPGC, is promoting the outward or the promotion of filtration. This is inhibiting it because we need to have this perfect. We don't want all the water and all the salt to completely leave our body in this area, or we're going to lose any kind of pressure for it to continue on. And of course, then we're not going to be able to reabsorb things correctly or have enough water and salts to basically have the right osmotic pressure as we go through the nephron. So we do have some that inhibit it. So we have some hydrostatic pressure in the capillary space. That's a space on the outside that is forcing some of the pressure in. So that's 15 millimeters of mercury. And then you have the osmotic pressure in the capillaries itself. That's pulling of the protein blood, and that's 30. So when we look at all this together, we can get a net filtration pressure. So the overall pressure are some of the forces that are allowing filtration to go through. And basically, this overall net filtration is a pressure that's responsible for filtrate formation, the overall sum end product, right? So we have forces that are promoting filtration. We're having some that are inhibiting it, so we can get just the right net filtration pressure rate. And that's what's known as a net filtration pressure. And that's the main thing that's controlling the glomerular filtration rate in the body. And so you can see here, right, that we have this pressure right here, basically the hydrostatic pressure of the glomerular capsule. That's the glomerular blood pressure that's going outward. So we have blood coming in here, so that's the pressure that's being applied on the water and the solutes to move out. But if you notice, we have two things, right? We have this guy here, which is a hydrostatic pressure of the capillary space. So as you're looking, we only have a certain amount of space here on the outside of the glomerulus until we get in that's contained in this Bowman capsule. So there is some pressure that's basically happening here and pushing against, because you can only have so much fluid in the space. And then also we have a certain solute concentration that's happening both inside and outside. And so we want to keep enough solutes inside here to pull some things back so that we're not losing everything. So when we add these together, basically you take your pressure of going out and then you add the two pressures going in, and we get this total 10 millimeters per mercury net filtration pressure. So that's what's happening here. that allows stuff to leave through that capsule. So the normal of this basically glomerular filtration rate, you get about 120 to 125 mils per minute, the volume of filtrate formed per minute by both the kidneys. And it's directly proportional to that net filtration that we just talked about, the total surface area of the cells, and the filtration membrane permeability, right? And so constant glomerular filtration rate is important as it allows kidneys to make filtrate and also maintain the extracellular fluid homeostasis. So there are both intrinsic and extrinsic controls for this. So the intrinsic control basically is this thing called renal autoregulation. And basically, and we are almost finished here. Just give me a few more minutes as we talk about this. So we have to, the main goal of the renal autoregulation is to maintain the glomerular filtration rate in the kidneys. And there are two types of this, the myogenic mechanism and the tubular glomerular feedback mechanism, two of which I'm going to show you in the next page. And then the extrinsic controls are both neuronal and hormonal. So we're talking about the nervous and endocrine system getting involved in here. And basically the purpose of the extrinsic control is to regulate this filtration rate to maintain the blood's body temperature. So kidneys trying to maintain basically the filtration rate and to get solutes and metabolic waste and toxins out of your body. But at the same time, you have to make sure that you maintain plasma levels, i.e. water levels too, and salt concentrations. So we're going to do that to basically you're going to have certain controls that make sure to regulate that. The extrinsic control will override renal intrinsic control if the blood volume is too low and it needs to be increased. And that increased glomerular filtration rate causes increased urine output, which lowers blood pressure and vice versa. So that's why we need to maintain these. And so if you look here at the top, you can see these are the two intrinsic controls and these are the extrinsic. So basically, if your system blood pressure goes down, a couple things can happen, right? And so the myogenic mechanism of autoregulation just says if the blood pressure in your efferent arterioles goes down, then it reduces the amount of glomerular filtration rate will happen. There's not as much pressure in there, so you're going to reduce the amount of hydrostatic pressure that you see in that filtrate. It decreases the mechanoreceptors, so you get less of stretching of that smooth muscle wall in the efferent arteries. So vasodilation of the efferent arterioles will happen so that we can get a greater glomerular filtration rate. Of course, if you, on here, when we're looking at the tuboglomerular mechanism, this starts with you get a reduction in the GFR, which means there's less filtrate flowing and less sodium that's going into the ascending limb of that nephron loop, or what used to be known as the loop of Henle. And so this acts on the macula densa cells of that juxtaglomerular complex of the kidneys, the one that you find in the renal medulla area that have the longer loops. And so they basically release a vasoactive chemicals that inhibit, and so, or they actually inhibit the vasoactive chemicals or release of them, and so then you get a vasodilation of the efferent arterioles, just like you did up here, and it increases. So this one right here basically does from sensing blood pressure or the changes in blood pressure. So they dilate, or vasodilation. Here they notice that essentially the filtration rate is lower, so it's going to turn on these cells into the kidneys to help with vasodilation. Now that's the intrinsic controls. The extrinsic controls are going to be more nervous system or hormonal. So basically what happens here is lower blood pressure turns on the granular cells of the kidneys. That releases renin. It goes through the angiotensin II pathway, and it does a couple things. It either vasoconstricts the systematic arteriole, so that increases the peripheral resistance in the blood vessels, and it releases aldosterone from the adrenal cortex, and that's going to allow for reabsorption of sodium in the kidney tubules. That will allow more water to be reabsorbed as well, and you'll increase blood volume, so your blood pressure goes up. And in the neural control, you basically the blood pressure reduces, so you have these pressure receptors called baroreceptors that are inhibited in the blood vessels of the systematic circulation, so that turns on the systematic nervous system. So basically things like norepinephrine is released by the sympathetic nervous system, and epinephrine is released by the adrenal medulla, and that causes these vasoconstriction and an increase in the systematic blood vessel. So that's how filtration is regulated. Now, that's just filtration, how we get from the capillaries into the actual nephron. Now, when we're going through there, then we're going to start reabsorbing whatever is there. So it quickly reclaims most of the tubular contents and returns them to the blood. Almost all organic nutrients are reabsorbed. Water and ions reabsorbed is hormonally regulated and adjusted. So it includes both active and passive tubular reabsorption, and there's two routes that substances can follow to be reabsorbed. There's the transcellular and the paracellular. So let's talk about let's actually talk about the paracellular first because it's the easiest. So the paracellular, basically what happens here is, if you notice, these are basically these tubule cells here, and then you see that there's an opening between the two. And so these, if you remember, are tight junctions. So basically for the paracellular route, that you have water and solute just goes straight through the tight junction and then goes out, diffuses through this interstitial fluid and into the blood when we go to reabsorb out of the tubule lumen, right? And so stuff that comes here, and these are limited again by tight junctions, but they can be leaky a little bit in the proximal nephron. So what you find here is things like water, calcium, magnesium, potassium, and some sodium, right? So that is the paracellular route, and that's pretty straightforward. Now, the one that's a little bit more complicated is the one that's called the transcellular. And if you can see, it's based on their name. Transcellular means it's actually going through the cell. Paracellular, you can think of paraprofessionals as with or next to. So it's between the cells, right? So basically what happens is you can see these microvilli over here. Remember, they're there to help to increase the surface area. And so the solute in water is going to go through this part. This is the apical membrane. Now, when we go through here, these guys, they're going to use essentially, when we're going through this part, these are going to use proteins that are active transport, and they're secondary, which is syn transport. And we're going to talk more about that here in a second. And so basically, they go across the apical membrane, they diffuse across the cell, and then they're going to go, either they can diffuse over here and go out and go into that, basically past the They won't go before the tight junction, but they'll go into this kind of intercellular space here and go out and then diffuse across and go into the capillaries. Or they will move through what's known as this side is the basolateral membrane. And once they go through the basolateral membrane, then they'll diffuse and go in here. So those are the two types. Now you might be asking yourself, essentially, why or how the water and the sodium go through. And it's based on the type of, basically it's based on the type of activation or the type of cells that are there. And so essentially what happens is if you look here, you have the cell on the basal membrane. The basolateral membrane here, right? And so if you look, they're pumping sodium out into that interstitial space. And that basically is by an active transport. And this is the primary active transport, which basically means it's a sodium-potassium pump. And as they go through, they are essentially just moving sodium from one side of the membrane to the other. Now this guy, because you're moving sodium essentially from this side of the membrane to this side of the membrane, is going to cause the inside of this membrane or the inside of the cell to become negative. Sodium's leaving, so you get a negative charge on the inside of this membrane. Well, because you get a negative charge, basically it's allowing the cells or whatever on the inside to pull sodium out in as well. Because not only, if you notice, we're losing sodium, we're losing potassium. That's a bunch of positives here, right? But essentially, because we're leaving sodium to go across into here, it's making the inside of our cell more negative. So essentially, it's going to push sodium from this side to go into the cell to help balance out the charge between the two. Now over here, this is also an active transport, but it's a secondary active transport. And it's synport or co-transport here. So if you notice, you're seeing two things coming across the membrane here. And so basically, this guy here causes the sodium to come in to try to make it less negative on the inside. It's causing things like glucose, amino acids, and some other items and vitamins to come in because they're being transported together with sodium in this synport or co-transport mechanism of the secondary active transport. And because of the fact that we're basically getting high water concentration happening over here, we're getting water also moving across because of this, right? From basically high to low using what are known as aquaporins. So that's causing, this one side is causing those three things to happen. Now at the same time, this reabsorption of water here is causing these two things to happen because water's coming in. Basically, these lipids are able to, because lipids are soluble substance, they're able to transport across as well. And because they're going down their concentration gradient, and then very ions and urea can actually go through as well. So we're getting all of these things happening all together at the same time. And a lot of them are codependent on each other. And so tubular reabsorption, you can look on here and see kind of what's happening and what's being absorbed. So if you look up here, this is the Bowman's capsule that we start. And so this is the, something is not quite, I actually have this. This is, what did it do here? I'm sorry, this somehow got messed up. So the proximal is going to be up here, not here. And the distal is going to be up here when we're going and looking at it. So you can see some of the main areas of absorption. And so when we're looking at it, a big amount, what we were just talking about, 65% of the filtrate volume reabsorbed is in this area. And basically we are reabsorbing water, some salt, some bicarbonate, and many ions, glucose, amino acids, and other nutrients here, right? And what gets reabsorbed here is, that helps in acid-base balance, is hydrogens and that ammonia, and then subdrugs. Of course, as you come down this way, a lot of water is going to leave. That's going to essentially help to, inside the filtrate that you have, make it more and more, increase its osmolarity. Here, you'll get urea being reabsorbed. Out here, or urea is not is going into the lumen. So when we're talking to here, we're getting reabsorbed when we're going out, and here we're gonna essentially get rid of things as we go through. So let me erase this again so that I can make more sense. And I'm sorry for this one thing. This makes me mad that I did. So no, this should be up here, that should be here, and then this should be here. And so yeah, here what we're losing when we're talking about this is essentially this is what's going back into our body. And this is going to be what's going into our filtrate or our urine. Here we're absorbing water, reabsorbing water into our body. Here we're getting rid of the waste product urea so that it could be removed. And here, because we've concentrated so much and increased our osmolarity in the filtrate here, we do that so that then essentially it can sodium and can leave out again and go and be reabsorbed back into the body. And the last reabsorption is here in this distal convoluted tubule area right before it goes into the collecting duct. This is if you have aldosterone, this is the area that sodium will be reabsorbed, or calcium if you have the parathyroid hormone. So these are both the endocrine regulations. And basically potassium gets put into the essentially the urine to be released if you have aldosterone controls. And then essentially down here we have the collecting duct. And so as you go through there, you'll see reabsorption of water and sodium and anything else that you may need depending on hormones. And so the last part is tubular secretion, and this is the reabsorption in reverse. So this almost occurs almost completely in the proximal convoluted tubules. It's selected substance that moves from the peritubule capillaries through the tubule cells into the filtrate. So things like potassium or hydrogen ions or ammonia, creatine, organic acids and bases, substances that are synthesized in the tubules, such as like bicarbonates. And it's basically, this is important for disposing of substances such as drug and metabolites. And I hit on some of those areas when we were looking earlier. And so basically here, you can just see the areas. And so if you look at the bottom picture there, you can see where they're showing you basically when you go through, a lot of water will end up leaving initially and get moved out during the descending loop of the nephron loop, so that essentially when you get to the bottom of it, you'll have a very high concentration of salt. And because during that, once you get into that bottom loop, nothing can really leave or come until you get back up, getting closer to the distal convoluted tubule. So once we get in there, because the osmolarity is so high towards the end, then that makes it easier for salt to leave and be reabsorbed. So that's how this essentially works. And they show you that basically the blue is all the passive transport. So that's essentially just using the idea that water can just flow through aquaporins. And the red is active transport. And when it gets really, really, really dark, it's going to show you the areas for which water is impermeable. So that's really those areas around the nephron loop. So these are important when you're talking about basically balancing it out and getting the right gradients. The osmotic gradients created by this nephron initially by letting water pour out of it and then making it so water or nothing can transport, and then removing sodium later. So urine, and I'm sorry, but my pen isn't working anymore. So 95% of urine is water and 5% is just solutes. And the nitrogenous bases that we get are urea. And so urea comes from amino acid breakdown. Uric acid, it comes from nucleic acid metabolism. And creatine is a metabolite of creatine phosphate. And so other normal solutes are also found in water, right? I mean, in urine. But when we go through, we can look at essentially use things like urinalysis to figure out if there's some kind of weird pathology. So abnormal high concentrations of any constitute or abnormal component of things like blood proteins and bile pigments may indicate pathology, but things that you naturally find in urine are things like sodium and potassium, phosphates, sulfates, or calcium, or even bicarbonates. And at sometimes high levels of any of these, and including things like indication of white blood cells, can indicate some kind of pathology. And those just kind of show you if you have glucose, right? The name of the condition, if you find glucose or high levels of glucose, is glucosuria, and that possible cause can be diabetes. Things like protein, names are proteinuria or albuminuria, and there's non-pathological causes. It could be excess physical exertion, pregnancy, severe hypertension, heart failure, and sometimes these can be initial signs of renal disease. Ketone bodies or ketonuria, which is accession, formation, and accumulation of ketone bodies. So this could be untreated diabetes or starvation. Hemoglobinuria. This could be a transfusion reaction or hemolytic anemia or severe burns. Biopigment, bilirubinuria, could be liver disease such as hepatitis or cirrhosis or some kind of obstruction of the bile duct or liver. Erythrocytes or hematuria, this is bleeding, urinary tract due to trauma or kidney stones or infection or cancer, or leukocytes and pyuria, and this is normally due to the common urinary tract infection. So other things that we can do besides looking at the chemical characteristics, we can look at physical characteristics. So, typically you have clear urine. Pale to deep urine is called urochrome, and sometimes it can be from pigments of hemoglobin breakdown. Yellow color deepens with increased concentrations here. Abnormal colors, pink, brown, or smoky, can be caused by certain foods or biopigments, drugs, blood. Odor is normally slightly aromatic when fresh. It does develop that kind of ammonia smell upon standing as bacteria metabolize urea and turn it into ammonia. may be altered by some drugs or vegetables. And you might notice that if you eat something like asparagus, it smells a little different, or even coffee. You can drink coffee and it smells like coffee for some people. Disease may alter smell as well. So patients with diabetes, sometimes you can smell acetone. pH is slightly acidic around 6. A normal range is within 4.5 to 8. Acidic diets, like diets that are high in protein or whole wheat, can cause drop in pH. Alkaline diets are typical for vegetarians, or if you have prolonged vomiting or urinary tract infection, it can cause an increase in pH. Specific gravity, that's the ratio of mass of substance to mass of equal volume of water. So specific gravity of water is about 1, and so the specific gravity for urine ranges from 1.001 to 1.05 because urine is made up of water and solids. And once we make urine, basically it goes through the slender tubes that convey the urine from the kidneys, and those are the ureters. Urinary bladder stores it, and the urethra is the tube that helps you connect to remove urine from the body. And there are different sphincters there. We have the internal urethral sphincter that's involuntary. It's made out of smooth muscle. And this is located at the bladder and urethra junction. And this guy contracts to open. The external urethral sphincter, this is involuntary. And basically the female, this one's tightly bound to the anterior vaginal wall on here. And the external urethral orifice is actually outside and anterior to the vaginal opening and posterior to the clitoris in females. The male urethra carries both sperm and urine. And there are basically 3 names for that. You have the prostatic urethra, which is within the prostate, the intermediate part of the urethra, which passes through the urogenital diaphragm from prostate and begin to the beginning of the penis. And then you have the spongiurethra, which is actually passes through the penis and goes through and opens at the external urethra orifice, which is the opening for both. They do have what are known as pyelograms, and these are basically x-ray examinations of the kidney, ureters, and urinary bladder that uses iodinated contrast material injected into veins. And basically this is an x-ray and so it's a non-invasive medical to help physicians diagnose and treat medical conditions related to the urinary system. And micturition is basically urination or when you're voiding. And 3 simultaneous events occur to allow this to happen. And so you have contraction of the torus by the autonomic nervous system, or autonomic, the opening of the internal urethral sphincter by the autonomic nervous system, and then you'll have the opening of the external urethral sphincter by the somatic nervous system. So basically the nervous system helps to control in this process. And reflexive urination is the urination that happens in infants. And basically the bladder, the stretching of the bladder activates stretch receptors. And that causes the activation of the parasympathetic nervous systems in the reflex center of the sacral region of the spinal cord. And that'll lead to the contraction of the detrusors and the opening or contraction of the internal sphincter. And inhibition of the somatic pathway to the external sphincter allows it to relax and open. So the activation of infants for urination is a little bit different, but maturation to the process that I talked about first happens between ages 2 and 3. And this is when the pontine control centers mature. And basically it'll help to those pontine storage centers inhibits micturition or urination. So that's going to inhibit parasympathetic pathways and excite the sympathetic and somatic efferent pathways. And basically these centers will help promote urination. So, and this just kind of goes over the controls of urination, and you can basically go through this a little bit on your own. So at this point, this is a little bit longer than I intended it to be, but I wanted you guys to have a really good understanding of the central being of the urinary system. So I will see you next week, and good luck. And if you need anything, let me know, guys.